Okay, we're going to get started here. It's 5 o'clock. Welcome to the August Human Services Committee meeting. I would like to call the meeting to order. First item is to approve the minutes from July 17th. Do I have a motion? Is there a second? Second? All in favor?
Aye.
Okay. Do we have anyone here today for privilege of the floor? Anyone for privilege of the floor? Seeing none, we will go to the first proposed resolution, which is to amend the Chautauqua County Department of Mental Hygiene and Social Services 2024 budget to include New York State rental supplement RSP program allocations.
Hi.
Hello.
Hi, I'm Diana Songer, the Deputy Director of Finance for Human Services, here on behalf of Mental Hygiene and Social Services, requesting to increase the 24 budget to include the rental supplemental program allocation, which results in an increase of $483,975 in expenses and the same amount in revenue.
Okay, so this is budget neutral.
Yes. Yes, it is.
First question you gotta ask. Are there any questions, comments?
So we received a 24-25 rental supplement number that's different?
So yes, that includes that's for the period April 1, 24 to March 31 of 25. So
Yeah.
only that's just the 9-month amount of that allocation. The rest will go to the 25 budget.
Gotcha, thank you.
And anything else?
Sure. This amount, what was originally anticipated? This is in addition to, or is this roughly it?
I believe this is the annual allocation. We didn't have it in time for the 24 budget, so I believe it was left out until we knew the actual numbers, and then they come and do an amendment to include that amount that's allocated.
Okay.
Sorry, you probably, because you're a finance person, you don't know exactly how it's gonna be utilized, or do you know? I know it's supposed to, it sounded like, based on the document, that it's supposed to supplement the rental cost for different people. And
Yeah, that's about all that I know about that, is it
Okay.
does supplement the rental for, I don't know what the eligibility is, but yeah, that is the primary purpose of the funding.
okay,
I would guess that next month when Diane comes,
that's a good time to ask.
Yeah.
she would be able to enlighten us a little more on that. And
Yeah.
okay. Anything else? Okay. All in favor?
Aye.
Thank you.
Thank you.
We have proposed resolution number 2, reallocating salary grade for case manager for health.
Good evening, Mike Falk, Chief Medical Officer.
Lacey Wilson, Public Health Director.
This resolution came about as a recommendation from the reallocation committee. Lacey and myself are asking this committee politely to consider tabling this resolution for now so that we can seek further clarification. We both have some questions in regards to this resolution, and we'd like to hold off for a month to address this.
Okay.
I'll make a motion to table it.
Okay. Do you have a second?
Second.
Okay. All in favor of tabling the motion? Or
Aye.
tabling the resolution?
Aye.
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 Thank you.
Okay.
And I think we're still next,
Are we still on?
but I'll.
Okay. 3, presentation. opioid strategic plan with Steve Kilburn, project director, and you guys.
Just introduce yourself real quick.
I'm Steve Kilburn, Substance Use and Addiction Services Coordinator at the Health Department.
Hello again. We are always so glad to be with you in these moments to just have some FaceTime with you, bring you up to speed with what we are doing in the health department. Again, I'm Lacey Wilson, the public health director, and Dr. Falk is with us as well tonight in regards to this presentation. I'm not going to take really any time to speak to the presentation. We're going to leave that to Steve, who really is what we consider our resident kind of county expert in regards to really prevention services and planning in terms of preventing substance use and addiction from the public health standpoint within Chautauqua County. But I did just want to highlight, I think, just how timely this presentation is. I'd love to say that Dr. Falk had foresight into the future for these things, but really I think it speaks to the thoughtfulness of the work that's been done really even prior to me coming into this position under Dr. Falk's leadership and with Steve and then other county partners, Trish and Mental Hygiene and also DSS, to really highlight the need for a thoughtful approach to preventing substance use, specifically around opioid use in Chautauqua County. I think we all recognize the issue. And it's not just even here in Chautauqua County. Obviously, we know statewide and really nationally this is an issue. But to really set this precedence from a public health standpoint and really call this out as a public health problem, I think brings another level of awareness and urgency to really solving the underpinnings and the root causes of how we've gotten here in the first place. I say it's timely because the state health department has just recently made a pretty monumental move to themselves recognize this as a public health really urgent issue. And just recently, the commissioner of the state health department appointed a senior policy advisor. So this is Dr. David Holtgrove. He hails from my alma mater, where I actually did my graduate research in public health. So I'm very excited about the opportunity that Dr. Holtgrove has come onto the scene, because I'm sure that we'll be able to connect Steve very closely with him. But Dr. Holtgrove is a national leader in drug prevention programs and also a public health expert. And he has a demonstrated expertise by way of his development of evidence-based national response plans to confronting the emerging challenge of fentanyl combined with xylazine in the illegal drug supply. So really, this is just a wonderful time that we've kind of set this precedence in bringing Steve into the health department. I like to say that Chautauqua County is always ahead of the curve, and I think this is another example of that, that we've really solidified that here within our infrastructure, and now to see it also at the state level, that they're really putting some teeth to this from the state side of things, is very encouraging. So with that, I'll turn it over to Steve to talk you through some planning.
Yeah, I want to say thank you for giving me some time. I'm going to attempt to do what is probably not by anyone possible, namely to kind of cover some ground regarding what is probably hard to imagine any other particular public health issue, and maybe any other issue for that matter, that's as expansive, pervasive, heavy in its extent and its severity as is addiction. But I'm going to give it a shot in about 10 minutes here to give a broad overview. But to the legislators, I've given you a copy of what is our strategic framework going forward, really building on work that's been done now for a couple of years. It's not short, although I think it's certainly within reason, but it represents the severity and the seriousness that this issue has across all kinds of sectors, as I'll try to highlight. So what I want to just kind of impress, I guess, upon the legislators is the thought processes that are going into and the discipline and the seriousness and accountability that we're bringing and have been bringing and are working to expand going forward to this issue of addiction. As I will make the point in just a couple of moments, most of your constituents are very close to the issues of addiction. And that is really a statistical reality. This is a pervasive issue, and not just Chautauqua County, of course, but all counties. So we look and have prepared what we consider an informed, comprehensive, and collaborative response to bring a public health emphasis to this issue. And by that, and I don't want to suggest that we're looking at all of those little circles up there on that graphic, but that is there to just demonstrate the fact, well, two things really. One, addiction is complex. There are no sort of simple solutions, and so it requires a host of parties to contribute to our county's response to this very serious issue. And secondly, what this graphic is intended to kind of represent is that a genuinely public health, and for that matter, just an effective approach, is one that's going to take into account all of these sectors so that we don't have left hand not knowing what the right hand is doing, if you will, but that we are in a kind of coordinated fashion taking very serious this very serious issue. So just to very briefly kind of highlight some of the sectors, again, not going through these in any detail, but we recognize, perhaps contrary to some communities across the country, we recognize the absolute crucial role that law enforcement continues to play in our county's response to addiction. Certainly in the traditional roles of enforcement and public safety, that is regularly reducing the availability of illicit drugs on the streets, and that does make a difference. But in a host of other ways as well, and again, not trying to take all of these in detail, but just to highlight a couple of things that we coordinate with our law enforcement around. Maybe this even came up at the prior meeting, but our sheriff's department, and particularly the county jail, represents really the largest treatment facility now in the county. Over 300 unique individuals were started or continued on medication-assisted treatment for opioid use disorder in that facility alone last year. That's in addition to the sheriff, the credit of Dr. Falks to invest in the treatment that those incarcerated individuals receive. And now with the hub operating, there is a very dedicated attempt to make sure that folks leaving jail are able to get the best chance at reentry successfully back into the community. And so, again, recognizing that law enforcement and the criminal justice system broadly plays a crucial role in our whole county's response. Quickly, to just identify the breadth of our county's response, certainly traditional service providers, prevention, treatment, recovery, harm reduction, as well as medical providers are, of course, a key component in our county's response, and we have all of these agencies, not only represented in the county, but represented on the Chautauqua Substance Abuse Response Partnership that meets monthly. I should have mentioned as well, in regards to law enforcement, we have a behavioral health law enforcement group that also meets monthly that I chair. Of course, again, addiction and all of its complexities brings to bear a lot of what we call social determinants of health, housing, its impact on transportation, social services, et cetera. And so it goes. So all of these in a comprehensive response is what constitutes a public health response to addiction. So this is our lane, And among the public health, I think, strengths to addressing this issue is around planning. So with that by way of kind of introduction, I want to highlight some of the things that are in the document there that you have in front of you. There are, as you'll see and be able to read in some detail, 7 priorities. These are based on really several years of experience working with multiple partners and other stakeholders throughout the county. The 7 priorities are there. I'll leave you to read through them. I just want to highlight a couple of them and then leave room for any questions that might arise. Probably the most public, certainly the most tragic consequence of addiction, of course, are fatal overdoses. And we track, of course, those and have been for some time. This bar graph represents the county's experience over the past 10 years or so with fatal overdoses. Like much of the country, you can see an obvious trend upward. In fact, last year, 2023, we suffered the highest number of fatal drug overdoses to date. So some months ago, I set as our, I think, ambitious goal, the reduction of fatal overdoses in our county by 33% over the next 2 years. So if that were able to be met, our bar graph would then curve and look like this. Now, today, over 7 months into 2024, I can report to you that this is where we stand. That's actually 20. I learned today that one of those pending was not a fatal overdose. In any event, that's where we stand today. And if things were to continue at that pace through the rest of 2024, and of course we know things can change, things can happen, but this is what we are on a trajectory towards at the end of this year, namely an over 40% reduction this year in fatal overdoses. So if we are able to continue at the pace that we have been on now for these first 7 months of 2024, we will meet the goal of 33% reduction, in fact exceed it this year. And of course we'll readjust our goals and look for next year to reduce those deaths, numbers of deaths even more. To just maybe even hone in on that very point of this reduction, which is, I hope you all recognize, a really striking accomplishment. Numbers not zero. There are still families that are grieving the loss of a loved one. But nevertheless, for a severe problem of the sort that our county has faced, to see an over 40% reduction is, for that matter, in any public health issue, is really quite striking. In the Dunkirk zip code alone, in the first 7 months of 2023, there were 10 overdose deaths in 2023. This year, there's been 1. So these are significant changes, and obviously we're happy to see the trend heading the way that it is. Highlighting just a couple of other things. Reducing the numbers of overdoses and, of course, overdose fatalities is crucial, but it hardly constitutes addressing all of the many consequences that addiction brings. And while we, as I said, really value law enforcement as an element to our response to addiction, treatment, crucial as a response to addiction, the way the curve really gets changed is prevention, getting far upstream. And some of those benefits don't get enjoyed for maybe several years, but it is crucial that we prepare a generation to be able to function and to resist what is unlikely to change in our culture in the form of exposure and access to addictive drugs. I want to just highlight both kind of where we are, at least at a high level, and where we want to be. This represents the 18 school districts in Chautauqua County. And this very busy map is only intended to represent those school districts that have some kind of dedicated substance use prevention curriculum in them. The first one there, Health Smart, is a larger health curriculum that BOCES makes available to all the schools in the county. And then the other three are evidence-based programs that address not only substance use, in fact, many of them don't so much as talk about substance use as much as resisting peer pressure, dealing with the kinds of things that can ultimately contribute to a young person experimenting with drugs. They're evidence-based, well studied, and they are present in many of our schools. So there are things happening in all of our 18 school districts that address prevention, but not in all of the grades in all of those schools. And it's almost hard to overstate the value of prevention in anything, really, but including in avoiding substance use issues. So we look in the next year, 2 years, to work with our county partners, Prevention Works in particular, to see the number of schools that are being presented with prevention curriculum expanded even more. Quickly then, just to touch on a couple of other things. I mentioned earlier that most of your constituents are probably 1 degree, if that, of separation away from addiction. And I say that because really based on national statistics, we could say that something to the tune of 18,000 of our county residents have a past year substance use disorder. That's across alcohol and illicit drugs. But what that really implies is that even a conservative estimate of the numbers of people that those individuals of addiction affects, 3, puts us into the majority of the adult population of our county. This is how pervasive addiction is across our county. And while we are certainly reckoning with the number, and again, this rate, by the way, is not uniquely high. This is the kind of national rates that are published. But recognizing that there's a large number of folks with the substance use disorder, there's an even larger number of family members who are themselves impacted. And family members, as I'm sure there's not really a person in here that doesn't know someone at least who has been affected by a loved one's addiction. The effects can be profound. So we want to expand the services that are available to support family members in our county, of whom we would count them into the tens of thousands, who are very close to somebody with an active addiction. And it's been not just here, but generally in the field, a somewhat overlooked population that we intend to prioritize services to support. The final thing really, and it's not explicitly on the strategic plan here, but I want to not end until I've made some comment about the economic impact that addiction brings. Obviously, it's the human toll that we are most focused on within public health, but the economy also has human implications. The amount of dollars that get spent on addiction and its consequences are massive. They're found, of course, across sectors, healthcare, the form of EMS, emergency room, et cetera, et cetera. We, of course, see them in the criminal justice system, certainly incarceration, but also enforcement, supervision, and the court system would largely dry up if addiction were sort of miraculously removed. Costs are in the workforce. And this is one area that economists really do often dig into, the implications of how illness and, frankly, premature death have on workforce and the difficulty employers can have with retaining and even recruiting people among a population who are struggling with substance use. And then, of course, workplace safety. And then social services, of course, in the form of public benefits, child and family services, and then other downstream impacts of addiction, the educational system, et cetera. So it's difficult to the point of impossible even to define how we would maybe measure the economic impacts of addiction on, say, Chautauqua County, but it's not impossible to estimate it, and it would be clearly in the millions of dollars annually, probably tens of millions. And I say that because the kinds of successes the encouraging trends that we see, again, most importantly, have human implications, but they also have economic implications. As one example, All-Star has reported 50% reduction in the responses that they have made that have warranted Narcan administration. So, we might say opioid overdoses. So a 50% reduction from 2023 to 2024. That's an encouraging sign about the numbers of overdoses taking place, or at least being reported. But it also is a significant reduction in the amount of money that's being spent on EMS costs. And that would be true across these sectors as we begin to make, well, let's say this, continue to make the progress that we've been seeing already. The only other thing I just wanted to mention before I offer some time, as much time, of course, as you want for questions. We've had now for several years this single site as a resource for our community called combataddictionchq.com. It's obviously a website, but it also includes the opportunity that people can just reach out for some personal navigation. Sometimes, as we all know, with any kind of a health issue, we may know that in general there are places to get help, but it's overwhelming. Where do we even start? We can help people get started. If you know of somebody that or has a loved one that needs some help, direct them to the website, but also encourage them to reach out for help. And then finally, I just want to give a proper shout out to our many, many partners across the county. These agencies represented here make up the Chautauqua Substance Abuse Response Partnership. Again, we've been meeting every month for the past 5 years, continue to do so right through COVID. And it's really the hard work of these partners. There's literally not an outlier among them in terms of sharing a common mission and a collaborative approach to addressing addiction. So I just want to be sure to mention that this is work that isn't so much coming merely out of the health department alone. This is collaborating and helping to strategize with all these partners. Lots more in the document that I've left for you. I hope you'll find that helpful to understand both the sort of landscape of addiction in our county and our plans to address it. If there are any questions, I'd be happy to try to address them. Yes?
So, a couple things. One, it sounds like 9 of the 10 in the reduction was in North County?
Correct.
Is that correct?
Yeah.
Okay.
And there's been, I think, 9 or 10 fewer in Jamestown, although the
But
percentage
percentage-wise,
wasn't as
okay.
dramatic, but yes.
What do you attribute that to?
Yeah, that's always the right question. And at one level, I would refer us back to that very busy circle graphic, to say that there are so many contributors to addiction, so many contributors to addressing addiction. But among them, I think almost certainly has been our success in the distribution of Narcan.
Okay, yeah.
And we, I think, again, this issue warrants a kind of discipline that we take very seriously and that we hold ourselves accountable to goals, etc. Among them, are we distributing a lot of Narcan? And I can say, yes, we are on track to, at least of those that I can account for, and there will be others, sources getting to people in the community, over 7,000 kids will go out this year alone. And by the way, I want to make clear that the state of New York is providing all the counties with this. That's not purchased directly by our county. New York State, I think, has made a wise decision to make it broadly available. And the good news about Narcan is, well, of course, the best news is that it does work and reverses overdoses. And it has there's no diversion. There's no other use of it. Nobody gets it for the wrong reason.
Just also to highlight too, I think, central to the point that you're making is Narcan is really, from what we would talk about in the public health approach, is really approaching and intervening at the individual behavioral level in a lot of ways, and community-based, because we're getting it out through a lot of agencies and organizations. So those same outcomes and those same positive outcomes that we're seeing in terms of individual behavior and individual awareness, we're hoping to shift in our planning to include, now that we have Steve on board, to really start intervening at some other levels of the socioeconomic spheres of things. So really working more in collaboration with our partners, and specifically kind of at the institutional and policy level of things, where there we can have a larger impact on the prevention of this behavior in the first place. Because we know so oftentimes that, you know, children don't on their own typically choose to take drugs unless recreationally or so. Oftentimes they're exposed within their environments and because of lack of their own control, or exposed in utero. So we realize that there are some areas, and highlighted by the 7 areas that Steve has in the plan, that we can be doing a lot more work that would actually have some larger implications, and see those trends, those positive trends. We could see those on a much larger facet of things.
So more from the prevention side.
More from the prevention side of things, and really kind of utilizing those aspects of policy and institutional kind of trainings and things like that that we'd like to see, that we know would stave off a lot of the initial use to begin with.
Yes.
I went to the pit count the other day in Jamestown.
Oh, yes.
So, and then, when talking to people, they showed the, not in just talking to professionals, they showed the xylazine, those
Yeah.
little packets.
The test strips.
And the
Fentanyl test strips.
How effective has that been for kind of,
We've certainly distributed a lot of them.
yeah,
They're kind of notoriously difficult to get, a kind of
measurement?
rigorous measurement of they work. I mean, it's not that there's any questions in the literature or otherwise about their effectiveness that way. The extent to which they're actually used and how they affect behavior is kind of still, I think, an open question. But it is worth noting, too, to your point, we talk, and rightly so, a lot about opioids. That has been the sort of epidemic, the crisis that our nation has faced, and it's almost always fentanyl involved when someone overdoses and dies. Having said that, I do want to make mention of the fact that we as a county face a very significant stimulant use problem. In fact, many of the instances where somebody does overdose and die of fentanyl, they've actually ingested it via methamphetamine or cocaine. So this is an sort of a burgeoning concern that we are tracking and responding to. It is, as a stimulant alone, it's less likely to produce a death, but it is producing all kinds of unhappy consequences downstream, not least of all the psychiatric implications of its use and its effects on our hospitals, et cetera. So that's still, of concern for us, and one we're keeping a very close eye on. And then, as you said, xylazine, and, there's always emerging other drugs that we keep on top of.
Has doctors been given a restriction on how they prescribe them? Because
Prescribe
they're
opioids.
giving them out opiates. Oxycodone.
Yeah, so there are, the prescribing of
Giving them out like candy.
pain medication has definitely been severely cut back. And Dr. Falk would
Yeah,
be
I
better
mean,
off, or better.
The DEA has scrutinized many of the practices that were typically giving out a lot of opioids. That's number one. Number two, the standards of care have just changed. Uncommonly do we as physicians prescribe opioids anymore. They're utilized frequently inside the hospital for painful procedures, surgeries, things like that. Painful conditions, trauma, that type of thing. But there are now more and more non-opioid techniques to help with pain. And so a prescription for, hydrocodone, 90 pills that somebody might have got post-operative in the past, that doesn't happen anymore. Yeah, very uncommon.
I would just add, I think to your point, that's a perfect example of this approach that we're talking about, where that's an intervention that happened not as the individual. So we didn't go out and educate individuals, refuse to take that prescription from your provider. That's an intervention in which, the public health world, we're working all together with, the medical model and saying, hey, this is something, what can we do here with these standards of care? Working with our providers and saying, there's ways that we can intervene there to stop the exposure and prevent the exposure that we didn't, have that, we weren't privy to that knowledge beforehand. We know that now, hindsight is always 20/20. But I think that perfectly highlights exactly what we're talking about, that there's opportunities to intervene and prevent that aren't just putting the onus on the individuals as well, but where we can go in and have much greater impact. I think it also speaks to Steve's point of the pervasiveness of this. So oftentimes drug use is stigmatized in our communities. This is a perfect example of the non-typical drug user that we would all think of. So many people have been exposed to opioids that are not that typical profile of a drug user. And that has made it so much more difficult. So many of our systems and programs are set up with that stereotypical person in mind. And yet, this is something that's affected so many more people and many more families, and in ways that we'd never set up systems or programs to intervene before. But we are really poised here in this county, I think, on the screen here. That is an indication of all of the different players and people at the table having these conversations within our county. And so many of these, and I would be willing to say all, have really mobilized very quickly to change their practices and their programs to meet these needs as they're able to. So as, significant an issue we do have in the community, we also have a very dedicated and comprehensive group combating it at the same time.
Can I ask, and maybe I missed it, but the fatal
Mm-hmm.
overdose has decreased
Yes, significantly.
and significantly, probably because of the.
Well, we would, I think almost certainly attribute Narcan distribution. But, I mean, as I mentioned, 300 some unique individuals were treated for opioid use disorder just through our jail. And I mention them in particular because, frankly, motivation to get into treatment is sometimes varied and might be, in other words, they are a population that might not have been in treatment without being incarcerated. So I don't think it would be a stretch to think that that too has contributed, along with lots of other things.
My question though would be, since the non-fatals are going down, or since the fatals are going down, are the non-fatal,
Mm-hmm.
you said, and maybe I got confused, that All-Star is the.
All-Star has also reported like a 50% reduction. The data that they gave me were the number of calls at which Narcan was administered. And by the way, to that earlier point about the distribution of Narcan playing an important role, another piece of data that All-Star has provided to me is that over the course of 2023, the instances in which, upon arrival at an opioid overdose, the EMTs discovered that the patient had already been administered Narcan before they arrived, rose to over 50%. So that's a testimony to the distribution of Narcan in the community. But to your question, yes, they have reported the number of non-fatal overdose calls having been reduced by about half.
So both non-fatal and
Yeah.
fatal have reduced.
The only sort of asterisk that I would put on that is that by definition, we're talking about reported overdoses.
Well, I mean, that's all you can base it.
That's all we can base it on, yes. But we know that there are many that don't get reported, but almost certainly they're being successfully reversed. So, mhm.
And can we count on New York State to continue to supply us with Narcan
I-
doses? Will that increase, decrease?
Well, honestly, we can get and there are many of our partners that get it directly. Doesn't all come through the health department, but we've had almost no limits to the number of kits that we've had access to. And I've heard nothing personally that would suggest that the state is questioning that. That's
And the fact that they're bringing somebody on in particular around this issue, I would think that if anything, there will probably be more availability to other wraparound services and preventive services as well. I think something also, significant to point out about this is we very thoughtfully have been moving forward calling this substance use and addiction, because I think it's important to highlight that for all of time, the abuse of substances has been a part of society. Where I think, and research really and just narratives are showing, is that we are now in a time where substance use has kind of moved out of that individual choice spectrum and into a place of almost predatory style business models in so many ways. So, I mean, these oftentimes now are businesses, and we see this everything, not just from the illicit drug supply, but to tobacco, to, THC, products and things like cannabis products and things like that. This is a different style and class of substances than we've ever seen before in society. These substances are developed to be addictive and to purposely addict people because it is a customer base and a moneymaker. So I think very thoughtfully we've put this together because, the implication of how we set up our planning and our infrastructure sets us up for a health promotion and a prevention-focused infrastructure, so that regardless of what the substance is of the day that, these predatory marketers have, found themselves in and can shift to, that there is an infrastructure from which we can pivot and respond, so that it's not a new system and a new world every time a new product is on the market.
And as most of Mike was talking, Dr. Funk was talking about some of the funding. You're getting like a lot of your funding from Oasis or.
Yeah, so I think,
Yeah.
so this strategic framework really sort of paves the way to help guide all of us in how we decide how to utilize our opioid settlement funds. So there's been two sources of opioid settlement funds for the county. One has come through the state attorney general directly to the county. So the last 3 years, I think upwards to the end of 24, will be somewhere around $2.7 million roughly. I don't have the exact numbers. We'd have to get those from finance. Most of you will remember over the last couple of years since we started our medication-assisted treatment program that was mandated by New York State in the county jail, we have funded that program with opioid settlement funds. That was a decision made by the county legislature. So, the budget for that has been, over the last, 23 and 24, close to $800,000 per year to fund that program. That's medication, staffing, nursing, et cetera. The other half of the other source of funding comes through to our local government unit, the LGU, under mental hygiene and social services, from Oasis. This comes to the county as a grant, which gives essentially the MHSS the autonomy to employ those funds independently. When I say that, all of us, Trish is here, McLennan in the back, Carmelo Hernandez, myself and Lacey and Steve and the county executive, we've all discussed, how we best employ these funds. What this strategic framework does is it really looks at the priorities. It looks at, what outcomes we can measure and potentially improve, and how do we employ the funds to give us sort of the most bang for the dollars invested. And that's what we really want to focus on. You know, a couple years ago, this came down, you know, the MAT program at the state, or came down from the state pretty quickly. We had to act and figure out a way to fund it. And those are the decisions that we made. Over the next few months, I think as we move towards our budget hearings, I think what you will be hearing is sort of a phased down approach to the use of our opioid settlement funds for the medication-assisted treatment program at the jail. You know, this year it may be a little higher, next year a little lower, the year after that a little lower, and eventually sort of phase that out. Most of the opioid settlement funds over the first few years came in as kind of a big bulk payment. The OASIS funds somewhere just shy of $2 million. But moving forward, 2025 and beyond, those funds are going to be in the $250,000 per year range coming to the county every year, you know, really indefinitely, at least for another 15 years probably. You know, and that may change as there are lawsuits out there, you know, that have not been settled yet, and when those are settled, those funds will come our way. So what we would you know, like to do, and what, you know, really Steve has been tasked with this strategic framework, is working closely with all of our community partners to really identify the priorities, that really get a firm understanding of what programs are out there, what everybody's doing, and then, you know, come back to this body to, you know, provide some recommendations in regards to how we can employ some of those funds. You know, they're not going to be in the millions of dollars. They'll be more like in the tens of thousands of dollars as we try to identify programs that we can help fund in the community. So we're going to be probably relying on many of these community partners and working closely with them as we identify important programs that they have ideas for, or they're prepared to start or begin. And you know, specifically for our Attorney General funds that come straight to the county, those are the ones that we are probably going to be up here asking, you know, for your approval through budget amendments and things like that prior to engaging with some of these folks. So that will probably be happening soon on a smaller scale as we start ramping up. So.
Okay. Anything else?
Thank you for having us.
Thank you.
Thank you. Okay, next we have the discussion, the CPS update. I believe we have Lori coming back. Olivia, could you pass out that printout? Lori, if you could identify yourself.
Lori Dulce, Director of Certification for Department of Social Services, responsible for child protection.
Okay, so we just, in the last meeting, we wanted to have some updates
Yes.
month to month and see where we are. I know Olivia's passing out something that was emailed this afternoon.
Yes, I believe that's the update that Carmelo Hernandez sent out regarding the current status of CPS.
Okay.
Just to kind of paraphrase what's in that, obviously you have it, I don't want to reread the entire thing to you. We have 0 workers right now with 15 or more cases. Every single one of our CPS workers is at 15 or below, which is the state recommendation, not mandate, but recommendation. I am cautiously optimistic that we will be able to stay there for a while. It's not unusual when the school year starts for there to be a spike in intake for child protection, but where we are now, I feel like we're doing an incredible job. I'd like to give a lot of the credit to the B supervisors that have been managing the caseloads and the workers. We currently have 3 supervisors doing the work of 4, and those 3 have done an absolutely phenomenal job with being able to work with their staff to get cases under control. So just wanted to make sure I gave kudos to them. We have hired, over the past few months, we've had 4 new workers start. We have 1 more worker who will be starting in about 3 weeks. CPS currently has 1 vacancy, which, again, I can't remember the last time that our vacancy rate was so low. The other piece that had come up was support services for our staff. Obviously, the county provides multiple supports for them in terms of EAP, support services within mental hygiene that our workers are able to access. We also, several years ago, I want to say it was about 2019, we have a worker-driven group that started. It was initially called Chautauqua Strong, and it was started by several of our caseworkers who are working on their MSW degrees and as part of their internship requirements. It was specifically developed to provide additional ongoing support for our staff from a peer perspective. Not a structured counseling or debriefing service, but more of different ways to engage in self-care. They've done meetings, they do monthly events. The event may be nothing more than we're gonna take 15 minutes and get people together. Anyone who wants to do yoga can do yoga. Anyone who wants to come in while we're listening to certain music, come in and listen to music. A way for workers to de-stress and kind of commiserate outside of the specifics of their work. It's generally staff-driven. We do have administration involved to help with facilitating and support, but over time the group has brought on new workers. It is open to any staff who are interested in participating, and we really encourage staff to take advantage of this. Most recently, our all-staff meeting was run by this group, and the whole day was spent with workers going from station to station, doing different forms of self-care. Music, dancing, yoga, just stuff to allow them to relax and help them process the things they're doing in this line of work. We are still working on ongoing structured long-term supports for our staff. I can say that I've been in this in this division for almost 17 years. We have more staff supports in place now than we have ever had in the time that I've worked here. We're working on one of the support services is CISM, Critical Incident Support Management. Trish, am I right in that? Okay, I just wanted to make sure I got the acronym correct. Which is, again, a structured, formally trained peer group that would help staff during crisis situations. We are looking at more kind of informal debriefing sessions that workers can come to when they're just generally having a hard time. Who are their point people that they can go to for support? We've recently started pulling together a group to work on a more formalized procedure for workers to be linked with these services. We have several workers who are looking to do internships for various degrees, who are going to do this as part of their internship, along with our staff development and along with our administration, along with supervisors. We're also bringing in staff and supervisor trainers to help address areas, things like secondary trauma or crisis management, things like that. Because unfortunately, we can't negate the horrible things that our staff are going to see. The nature of this job is that we are called when bad things happen. That is going to be what our workers are dealing with. And I think most of them know that that's what's going to happen. It's very different to have an expectation that something bad will happen than it is to necessarily walk in the door to that horrible thing. But I think that building that network for staff, within the people who understand what they're doing every single day, will be a great resource for them. The only other thing I wanted to touch on, and then I'm open for questions. I know that after the last time I spoke, Some of the workers who were here that day did raise concerns that they felt some of the information that I relayed wasn't specific to CPS in terms of retention and in terms of our staff. So I pulled specific numbers. Going back over the past year, this would go to, to August of 2023, we have had 4 workers leave and 1 retirement. That's, given the type of work we do, given the type of horrible things that workers see, that's an incredibly low number for turnover. One of the workers was relatively new, not even trained, and just decided very early on that this was not the field for them. This was not a good fit, which is wonderful insight for somebody to have, because not everyone can do this work. So taking the 1 retirement out and taking the person who realized they were in the wrong place, we've had 3 workers over the past year that have left the agency. While any loss of staff is a lot, especially when you look at the training needs, the intake needs, all the things that we deal with, that number of staff in terms of turnover is not excessive. This list that I have goes back to 2016, and that includes retirements, services workers. And the people who did leave didn't leave because this place is terrible or this job is terrible. It's, I'm going back to school. I have a degree and I've got an offer for a promotion in the community. So if that happens, I think that's great that they're taking the knowledge and insight that they have from working with child protection with them to that next job, because then it helps us with ongoing education in the community. So that's what I have for an update. Are there any questions at this point?
Thanks for that information, Maureen. One thing I had on a list that I had sent to Carmelo or to Mr. Hernandez and Mr. Anderson was develop a written plan and protocol for backup for law enforcement in the instance where local law enforcement is not available. Particularly this was a stated problem in Jamestown.
So I've been trying to track down the information in terms of what happened specific in that situation. I think the biggest concern is our workers reaching out to law enforcement as for a peace officer assist or as a 911 response. I have not heard of any workers who have reached out as an emergency response need and not received immediate response from law enforcement, same as anybody else calling 911. When it comes to a peace officer accompanying staff, yes, to some extent, we do have to defer to law enforcement, because if they have a crisis going on, our home visit may not be their immediate priority. And that's okay. If it's an emergency situation, our workers would do like anyone else in the community and call 911. I'm not aware of any situation where our staff have reached out for an emergency assist and not received an immediate assist from law enforcement in any jurisdiction. We have had situations where we've been told by law enforcement, this is not a great time for us to send a peace officer, but we'll reach out to you when we can. And they do. They're very good about responding to that when we need it. In the event that we run into something that is kind of in a gray area, maybe it's not 911 worthy, but we need to act on it a little faster, we have people who are available. I mean, if we've ever placed a call to either the sheriffs, the police departments, anything, they've been exceptionally responsive to our needs. It may be a matter of not going through dispatch. It may be a matter of calling somebody and speaking to somebody directly, whoever the officer on shift is. But we've never had a situation where law enforcement has told us we're on our own. So I think it's just a matter of how the workers are presenting their needs to law enforcement, whether it's emergency or whether it's we need some support, but it's not an emergency situation.
So in terms of sort of defining the two situations that were told to me, they were situations where the CPS worker had to make a visit. And when you say peace officer, that's still the same police officer, right?
It would be a law enforcement responding to assist without it necessarily being an emergency call. They're there basically to provide support to our staff versus responding to whatever the situation is in the home.
So my understanding is that the situations, two, I only know of two, were, and again, as I've said, the workers said, yeah, the police are really great, but there are some, I did some reading on it, and I think that sometimes what happens is between shifts, or if there are, if there is all of a sudden something really dangerous that where you need a lot of police to go and they can't spare an officer, but, so it's like a call to a police officer saying, I need someone to go with me because I have concerns about the safety of the situation itself. So like you said, it's like a gray area. And, I was given two very specific instances. So is it possible that you could, is that something you've heard of or you haven't really?
Generally, no, that's not something I've heard of. Like I said, we have had situations where law enforcement have said, for whatever reason, this exact time will not work for us, but if we can adjust the time by a couple of hours or schedule, a different time to go out there, they're always willing to work with us. If it's a situation where workers feel and have a genuine reason to feel unsafe walking into a home, we do get reports that will say, yes, this family has weapons in the home. Yes, this person is violent. Or we'll get a report that says there's violence occurring right now. Somebody is being assaulted right now. In situations like that, we call law enforcement directly and ask them to respond before our workers go out, because our workers are walking in with a clipboard or a computer. They are not armed. They are not in a situation where they can physically defend themselves from something like that. But if there's something where we're concerned about the immediate safety of our staff, whether it's during the normal workday or after hours, we would call law enforcement directly and ask them to be the first responders, and we would come after they've either told us that it's safe or they will remain while we're there. It is, I say, there's two cases that have been brought to your attention over the course of what period of time. Do I think there's situations where law enforcement has other emergencies that are bigger priorities? Absolutely. I understand that happens. And same with us. We've had night shifts where we have 2 workers. We've had night shifts where we've had to have 6 because it's a full moon and things are going crazy. I think law enforcement operates the same way. But we've never had a situation where law enforcement has refused to help us. Sometimes we've just had to have a little bit of extra time to be able to, accommodate. Because the other piece of this is, even if we had an additional resource available specific to CPS, this is a big county, and it can take over an hour to get from one end of the county to another. The chances of a worker still having to wait to get some sort of response are pretty good. We never require that workers go out to a home by themselves. I have been willing to go out and do home visits with staff. Many of our supervisors have. I know that Carmelo has even gone out in the field with our staff to home visits, because worker safety is important. And this isn't just for child protection. Our services workers, the ongoing preventive and foster care workers, are going into the same homes, working with the same families, seeing the same things. If a CPS worker isn't available to support another worker, there is someone from services who is willing to go. We have never required a worker to go out by themselves if they felt unsafe, and will not do so.
So it sounds to me like you're saying you don't really think that, you've got every situation pretty much covered, and that you don't really need a backup police, like a written plan or protocol to follow if you can't get police or you think something is dangerous in the house, but you're not.
I would hesitate to say that we as social services could write a plan for law enforcement as to what they have to follow for us. I can say that if we've ever had a situation that we felt we needed law enforcement presence, if we can't get someone from that jurisdiction, even both of our offices have a police presence. I don't think we've ever had a situation where we've not been able to get support from law enforcement within a very reasonable amount of time.
I'm not talking about a plan and protocol for police, but like a plan and protocol. It sounds to me like you're pretty certain that this isn't needed, but this was one of the things
of course
that I shared, which was from CPS workers, and I'd be happy to share with you this person's name. It's not like they said it, I'm not gonna say it now, but I would give it to you, give her the person's name. But the idea that to develop a written plan and protocol for what to do in this particular instance, and that might be developed with the help of CPS workers.
Well, and we have policies and procedures for daytime and also for after hours. And this is the reason that before a worker goes into a dangerous situation or a potentially dangerous situation, they are always to consult with their supervisor. That is rule number one, particularly after hours, either nights and weekends. And the supervisor ultimately makes the decision, especially after hours, as to whether that's something that needs an initial response immediately. We have 24 hours to start an investigation, so sometimes we'll get a report that we have a little bit of time on. But the supervisors will make the decision with the worker based on what they're reading on paper and what they know of the family as to whether this is something that our staff can safely go into or whether it is something that we have to direct to law enforcement to start. It's difficult to quantify it in a formal protocol because every situation that we get is different. We may have a case that comes in that doesn't allege anything about weapons, but we know the family, we've had experience, and our workers know just based on what they've seen in the case record that this may be an area of concern. Our workers their job is really in a lot of ways to make life and death decisions about other people. I think that most of our staff are well equipped to make educated decisions about their own needs when it comes to support in the field. I think that to an extent, having a formal checklist of these are the things we need to go through could actually hinder the process to some extent. Our supervisors take worker safety very seriously. I am available after hours. Melissa McMahon, my partner, is available after hours. John Anderson is available after hours, and so is Carmelo. If at any point in time a worker talks to the supervisor or a member of administration and does not feel comfortable with the information they're being given, they have our personal cell phone numbers. They can call us at 3 a.m. and we will answer. And I think that is, in a lot of ways, our protocol and procedure for a situation like that. If there's a significant concern, if it's a matter of we need to have 5 people on a conference call to decide how we want to proceed, that's what we'll do. We are painfully available to our staff. I have taken calls on vacations. I have come in on the weekends to assist with things. And I think that most of our administration would do the same thing. Supervisors have come in on the weekends and helped. This is a group that understands what each other does, understands the risks that they're putting themselves in when they walk in, and to some extent, limited resources they're walking into a home with. We always joke, okay, the police walk in with a gun, probation walks in with a gun, we walk in with a clipboard. But our workers aren't getting hurt in the field. They're respectful to people. They know how to talk to people. They also know when they need to just walk away and seek help, seek additional support from another means. It's a skill that sometimes takes time for workers to learn, but this is also why we don't always make our workers go out in the field individually. We have them go in pairs when needed so that they can build that experience that will allow them to make those judgment calls in the moment.
Thank you. I appreciate that. I did have another, so I sent this letter on July 30th to pretty much everyone. I don't know if you've seen it at all.
I just tonight had
Okay.
access to it, so.
Yeah, and so there were specific things that were discussed at a meeting that we had with John Anderson and the county attorney and Carmelo. And we discussed certain things, and one of the things was the idea of that there was some contradictory communication within CPS. Sometimes people are getting different messages, and I know that's kind of a tough thing to ask, but is that something that in any way is something that you have perceived or is being addressed, or is anything, you know, I guess that's what, I have an actual sentence, but it's referring to increase CPS stakeholder access and decrease contradictory communication, which I listed. There were like 10 different examples.
I wasn't party to that specific meeting, so I'm not sure exactly what information was discussed and what the specifics were. What I can say is there have been situations, and this is not, I know this is not unique to our area, where workers will, to some extent, supervisor shop. If they don't like an answer they're getting from one place, they'll get another one, and then it's, well, you know, but a lot of times we're making decisions based on what we know. I think the last time I was here, I did allude to the fact that there has been a lot of turnover, there has been a lot of change, there has been a lot of adjusting for our division over the past couple of years. Do I think that anyone is deliberately going in and having conversations with workers for the purpose of misleading them? No. There are a lot of things in our world that do unfortunately change day by day. Without knowing too many specifics, there are things regarding our requirements, working with the court system, working with law enforcement, state regulations, many different things that are very fluid in our world, and what is true on a Monday may not be exactly true on a Friday because a new regulation may come down or a new requirement. So without having more specific information, I struggle to give too much information on that.
I mean, I kind of feel like it doesn't make sense for me to read all this.
Okay.
I can. I mean, I did send this to everyone, and
We've
also.
all read it.
Okay.
We've all read it. And so, I guess, you know, one of the things that Jamie had requested, or legislator Gustafson had requested, was to have a follow-up meeting for 3 months, and that maybe it would be good to actually address some of the things in the letter, if that would be.
I believe you said you had sent this to John Anderson and Carmelo, and when I did speak with John Anderson this afternoon, and he said that he had provided information to Carmelo and to Anna regarding some of your concerns, again, without me knowing too much detail. But I would say your best bet would probably be to discuss that directly with John or Carmelo, to see where that information is.
So could that be part of our, our next meeting then? A discussion with Carmelo and John as.
I can't speak to my department head, but
Yeah.
I can let him know that that's a request.
I mean, I guess I don't think that, I've got like 10 specific instances. I went through all the notes and the committees and the different things that were said, and they were quotes from meetings and stuff. And so I'm sure that nobody wants to stay a great deal of time, but I think that, some of these things, I think that I personally would like to go through some of these things. I thought that there would be, John Anderson said, I did see him the other day, and he said, refer this to Carmelo, because I asked, he said he was going to send me a list of things. I sent this letter as a follow-up to the meeting and said, hey, this is what I, in my recollection, I did some more research, here's this information. And so I was hoping, he did specifically say, no, the answer's not coming from me. It would have to come from Carmelo. So is it possible that we could meet again, Chair? And
Yeah, I can invite Carmelo. We've committed to updates for the next 2 or 3 months, so.
And my role here is to update really on the functional status of CPS, where our workers are, where our staffing levels are, where our caseloads are, and where our staff support is. That was my purpose in coming, to provide updates.
We appreciate that.
If there's anything, yes, I would say if there's anything at a higher level that needs to be addressed, that really should go directly through Carmelo.
Yeah, and I can't speak to Carmelo's availability.
Right.
As you said, you can't speak to that, but and neither can I. I guess, my concerns are that we're staffed, and we are, except for one opening.
Mhm.
We are staffed. And it's still, now there are 4 provisional?
We do have
or
3 provisional workers.
Okay,
The
The
exam is
last
scheduled
meeting-
for next month.
right. In the last meeting, you said there were 3 provisional, and you were looking to hire
Mhm.
one more.
We did have one person who ended up accepting a different position within the county.
Okay.
So unfortunately, we did lose her from CPS before she even started, but we have now filled that position. And when we've looked at our staffing levels, because this is a field that has high rates of turnover nationwide, there is a buffer built in where if we have a few staff positions not filled, we're still at full staffing capacity. Looking at the possibility of people being out on medical leaves, illnesses, or people who just leave for whatever reason. We did build a buffer into our staffing, so we can be down a few positions and still be fully staffed.
And our caseloads have dropped too.
Dramatically. The work that has been done within CPS and also with the assistance of our services workers and supervisors is incredible. The amount of work that they've put in, the amount of time and effort they've put into supporting each other and bringing these caseloads down to what is a much more manageable level for everybody. I'm exceptionally proud of the work they've done.
That's great.
Mm-hmm.
Thank you.
Anything else? Any other questions, comments?
Okay.
Motion adjourned.
Sorry, just wait 1 second, sorry. I just want to say something about this letter and about the meeting that we had before. And this is what, I was asked to come to a meeting, so I came and we had a discussion. And then I did send this letter for clarification and talked about some of the things we talked about in the meeting. And without going into detail about the meeting, I, and I don't like to put you on the spot, Lori, and I'm not, you're done.
You're fine.
But I think, part of my concern is that, that I have heard nothing. I have heard nothing since I sent this letter about this meeting or anything. So when I'm coming to you and saying there are things that maybe could be discussed, that's where that's coming from. Thank you.
Thank you, Lloyd.
Thank you.
Appreciate it. Do you have a motion to adjourn?
Second.
We are adjourned.
Thank you, Lori. Thank you.